Today's topic that we're going to be talking on is the cost of violence in healthcare, compliance, coverage, and consequences. And joined here by my co-host, Jose Delgado Jr. He is, again, for those tuning in for the first time, he's been on quite a few episodes, but just a little background. He's 20 plus years of experience in healthcare consulting, currently owns and operates a mental telehealth clinic. And this is actually a topic that you sent my way, Jose. So I'm looking forward
Yeah.
to touching on. I'm going to put the article in here that we're going to be referencing as well. I'm going to throw it here in chat.
Yeah. So for a little bit of background, every once in a while, about once every 6 months, something hangs about workplace violence. And so it's kind of interesting how it works out for facilities versus smaller offices based on um, different liabilities that are in place. But this is something that specifically the article I sent you was the AHA
Yeah.
paid the University of Washington to do a study on the costs and different things of that nature with workplace violence. And the CDC has some stuff that they were looking at and they released and published last year. Actually, almost a year ago, 5/29/2024. They
Yep.
were talking about workplace violence. Now, something interesting for me here was, and I did not know this, I knew that in comparison to other industries, the healthcare industry has a very, very high rate of work violence in comparison to the other industries. I did not know, however, that it was to the tune of
18 point.
triple of all of the other industries combined.
I saw something in the article, 18.3 billion in violence related cost.
Yeah,
Absolutely
so that
crazy.
18.3 billion, that's only for hospitals. So we'll break
Right,
that down.
right.
But for me, it was one of those things where I was like, holy crap. We're talking about over all industries, workplace violence, healthcare is the highest. Now, if you're in certain settings, this makes sense to you. You're like, of course. If you're in other settings, you're like, how did we get this high, right? And basically, what you've got to consider is that workplace violence comes from three different things. All right. Internally, from employee to employee or supervisor to employee or employee to supervisor,
Right.
interpersonal employee. Second, from patients and their families to healthcare workers. And this one you can imagine happens a lot more frequently in certain places that are, for example, Baker acting against people's wills, or if there's traumatic experiences and blame is being placed on providers or staff members for lack of proper care or whatever, right? And then the third one being actually spouses and partners of healthcare workers against the healthcare worker or their environment, their workplace,
Right.
right? So the way that the 18.5 billion is crazy because they basically split it up between 4.5 billion was spent on premeditation and 14 and the remainder,
Post
the 14, the
post
lion's
incident.
share was post incident,
That's a lot.
right? So
Post after.
so go ahead.
It's high. I was saying the post incident costs are higher than the prevention cost.
Oh, absolutely. And it's pretty obvious, right?
Yeah.
Here's why. Here's how you calculate and how it jumps up so freaking fast to triple, almost quadruple the amount of the pre. The post is having to deal with the actual any injuries that actually occurred on site, right? Replacement pay for those employees that are out recovering from injuries. Then there's any longer term, more subtle situations, for example, dealing with PTSD, dealing with survivor's guilt, dealing with, different aspects, if there's any lawsuits that come into play for perceived or actual malfeasance on the employer or the facility, right? So when we look at this, we got to kind of break it down because there's things that we can avoid and things that we can't. This obviously is a situation where pre is a hell of a lot cheaper than post. So, depending on the kind of office and specialty I have, again, that number drops exponentially, right? If a hospital versus a smaller outpatient office versus an office that is located in a facility like a hospital, you're renting out a unit versus something that's freestanding and all by itself. It all kind of plays into the same game. And depending on the type of subspecialty, you're not going to have the same a liability, right, or a risk assessment if we're using, administrative language. If I'm a primary care office versus I'm a mental health or
Mhm.
opioid use disorder or pain management, right?
Right.
So you have different liabilities and risks that we have to take care of. One of the things that is very, very simple that we all can do is make sure that all of our doors that are faced externally and to patient waiting rooms are locked during the day. It sounds basic, it sounds common sense, but you'd be shocked by how many people don't do that. You would be shocked by there is something to be said for not overworking your people. And what do I mean by that? I'm a huge capitalist, okay? I love capitalism. I love profits. Profits make the world go around, okay? I'm a firm believer in that. However, there is a point where you get diminishing returns from your people. And different people work better in different ways. So I may have my office set up and say, hey, based on the way the providers want to practice medicine, they only want to do 4 10s a week or 3 12s and a half day. Okay, cool. But my support staff may not work in that same way or may not like working in that same manner. So perhaps to reduce burnout, we will do 5/8 for the support staff, or we'll stagger the schedules. So even though it's 3 12s, everyone is working 5/8, but 3 of those days, some people are coming in earlier than others, and
Right.
some people are staying later than others. So that way you offset different things, right? This is kind of common sense, but again, burnout is one of the leading causes of interpersonal workplace violence. Another one is perceived or actual discrimination, right? So if I have, for example, a larger office, let's say, my organization is 50 to 100 people, and I've got like the main office, the main clinic, plus a surgery center, or plus a dialysis center, or plus, you know, um, a therapy or wellness side, right? Like I've got 50, 75 people. It's a nice sized office. I take up the floor of a half a building, a nice sized building, right? Okay, cool. I can have some interpersonal issues because it's perceived that, oh, the clinical staff is treated differently than the wellness team. And that can cause friction as well. You can't stop that kind of feeling. That's just the way interpersonal relationships work. But if it's something that it's obvious, if we're not addressing different situations early, then these things can fester, right? I don't want to turn this into a whole HR speech, but a lot of things that we can nip in the bud on the front end help us a lot on the back end. If we don't look at it on a cost side, we look at it on a disruption of business side. If you have workplace violence occur, or even a situation where the cops get called and your place gets shut down for a day because maybe there's an active shooter, or maybe you just got swatted. For those that don't know, that means that, the cops get a tip that there's an active shooter, they surround your office, they act like there is an active shooter in a hostage situation, which then puts you on the news and it causes all kinds of PR ramifications. Not a good look for anybody, right?
Right.
So we want to make sure that those kinds of the interpersonal pieces are set up and standardized. All right. CDC even talks about in regards to workplace violence. They talk about accessibility to the healthcare workers. So how are patients interacting with healthcare workers? Is there certain places that are off limits for patients that they're just walking into, or are there barriers of entry into different areas? I've got a small office. For example, we're in mental health. I've got a bullpen. That bullpen door is closed. They have windows that they can speak in and out of. My team doesn't like it when I tell them, hey, you got to close that door, especially when patients are coming in and out, because I don't want them coming in to the bullpen. It's an enclosed area. There's only one way in and one way out. It makes it very difficult without causing injury to move someone, right? So, and of course, if you touch anyone as an employee, you touch a patient, get ready for that lawsuit,
That's
right?
right.
You know, they're coming, right? So just prep yourself. So it's really a matter of if I can, and it's not avoiding, but if I can prevent the situation from occurring from the jump, then I don't have to worry about it on the back end. One of the other things that we talk about is patient families or patient advocates. Sometimes it's not even the patient that's upset with you, but the patient families can be a point of tension because they're playing a game of telephone, right? You know, if this is your mother, your father, your spouse, your kid, let's take the kid one out of the way. But the spouse, mother, father, uncle, cousin, adult, right?
Right.
You're receiving second hand, if not third hand, what's going on with the patient. And if they're not getting better, you're getting frustrated, especially if you're the one to and from and taking care of the patient. So it becomes very contentious. Man, I got to take another day out of work to take my dad to this doctor, and I don't think he's doing anything, or my mom's not getting help by this person. She's just a legal drug addict now. You know, like you get these kinds of situations that just build tension. And there are times when it's better that when that occurs, you have the paperwork from the patient that allows you to speak and clarify information. So I'll give you an example that we had in our office a little bit ago, not too long ago, but a little bit ago. We had a patient came in from another provider with a very specific cocktail that we were not going to refill because it was harmful to the patient. Okay. The problem is that the patient is upset because they came to the eval thinking they were going to get their pills that they've been getting for the scripts that they've been getting for 5 to 7 years.
Right.
And our provider is not comfortable with that and said, hey, we can do this, but I'm not doing what you came in with. I'm not refilling it. It's not good for you. It's not good for my license. Perfect. In our office, we back the provider as long as it makes clinical sense, right? So he notated everything. I spoke to the provider, looked at the note, confirmed that they matched up. I spoke to the patient's spouse, and I was like, "Hey, do you know what these drugs do?" And a lot of times, the patients don't know a lot about the condition or about the
Side
treatments.
effects.
Yeah, and the side effects. So it's something to where I'm like, hey, the reason why our provider is uncomfortable with this is because your spouse has certain conditions that can make this rather dangerous. If she takes it the wrong way, or she doesn't take it, or she does take it the wrong way, it can cause a lot of issues. And it's just not worth it. You know what I mean? So it becomes a situation where once we got to figure out why the anger is there, right? We got to dig down and do a little bit of work when that starts happening. Okay. Why is this patient mad? Why is this patient's family mad? They feel like they're not being treated properly. Okay. What do they think should be happening? And if we explain why something is happening, you get that, you get a little bit more, how can I put this? Buy-in. And if you get buy-in from the family, your patient's more likely to be compliant, which means they'll get better, which is better for your overall profit margin, better for dealing with quality scores, better with dealing with the insurance companies, better with the overall PR of the situation. You know what I mean? Like there's a lot of side effects here, right? And then of course we limit any John Q situation. If anybody remembers that movie,
It's
that got snuffed out real quick. Denzel should have gotten a friggin' he should have gotten awards for that one. But anyways, we won't
no,
do
it's
it.
this is a
Anybody
good
wants to,
I
huh?
was, I was gonna say this is a good example, because I mean
John Q is a great example. Absolutely amazing example. However, the John Q situation has a lot to do with the way the insurances work. which causes a whole nother conversation, right? So let's leave the John Q situation there, but notate that something like that can happen, and the reason why is very simple. Now, that is a conversation where we have to explain without blaming. Here's another example of what I mean. Patient calls upset. Why? For whatever reason, their medication is unavailable to their pharmacy or any pharmacy in the area. This
Hmm.
happens quite frequently with amphetamines. This happens sometimes with pain management drugs. This happened a lot during COVID. So a lot of people got practice with this during COVID. Well, what do you do? Well, there's not much I can do. I'm the provider. I can't make the drug in my office kitchen, like I don't have that kind of situation going on. So, but one thing we cannot do is go and blame the pharmacy. Hey, I don't know why your pharmacy is being stupid and not giving it to you. That doesn't help anybody. And vice versa. Hey, I don't know why the provider hasn't sent in the script. Well, because for whatever reason, you didn't want to fill out the script. Okay. But you didn't explain to the patient what was the issue. You just said it was wrong, provider's dumb, and provider needs to fix before I'll fill. That's that antagonism just creates more problems
So
and more
yeah.
anxiety and more stress and more anger, right? And then somebody has to eventually be the adult or things are just going to pop off, right? So we've got to be more collaborative and have a little bit of grace with our partners when it comes to that, right? um One of the things that we got to do as well, there's a CDC also said, discussing what kind of patients could be the ones that you should flag until told otherwise, right? Hey, during the evaluation, we noticed that the patient was rather agitated, has a history of agitation or aggression. Okay, that person needs to be flagged so that way we deal with that person with kid gloves. Hey, so and so's parents are really unstable. Maybe this is a good candidate for telemedicine. They stay home, they don't bring the nonsense to the office, if you will, right? So um, that may take a little bit more collaboration between the clinical and administrative staff, but that can be something that can easily limit if you're finding that, hmm, I don't have to be a statistician to know that this kind of patient is really upset a lot.
Right.
And yes, you are profiling. That is the nature of things. I'm not saying that you need to racially discriminate. I'm saying that you need to profile based on diagnosis. Insurances do it all the time. That's how they determine what they charge you. So, I mean, all we're doing is notifying, and we're not denying care, but we're adjusting so that way we have the staff in place for if something were to pop off, or they would know that they could see that we have staff that will not allow for certain situations to occur, right? Let's say that you're in an autism facility and you have one patient that you're working with that some days are really good, some days it can get violent. Okay, well, how do we prevent that patient from getting hurt? How do we prevent that staff member from getting hurt? Because if I'm the corporate admin, owner, manager, this is a nightmare. The patient is a liability, the staff member is a liability, and putting them together is just potentially causing me a lot of pain. So we've got to figure out, okay, what can we do? Is there something that we can do? Or is this a situation where maybe we have to discharge the patient because we're not outfitted properly to treat that case? We have to know that sometimes in our pursuit of always finding patients, we have to understand that sometimes it's within our best interest to not deal with certain types of patients that are not appropriate for our setup. You have to be okay with that. And your team has to be okay with saying, hey, look, this. If they have a case where they're like, no, 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 I'm really going to bat for this. Perfect. Then this is where that teamwork comes in and says, okay, well, then how do you want to prevent this? How do you want to prevent this from reaching a point of no return? hey, let's set up certain type of room. Hey, let's make sure this person tends to work well with this person, using the autism example. It tends to work with Bobby really well. Okay, so let's not put the patient on Susie's days. Let's put them only on Bobby's days. You know what I mean? So there's different ways that we can play with this. One of the things I like to that I've seen other offices, I don't normally recommend it. I'm a little bit more of a casual environment, but spouses can only come and visit if they're coming for lunch. They can't stay in the office. So there's no real reason for the spouse to ever get past that waiting room area. Right? So then we don't
Yeah.
have the situation of that spouse or partner causing any issues with other staff members. You know, depending on again the location, everything else, perhaps there's plexiglass in between you and the patients in that waiting room. Similar to a bank or similar to during COVID times. On other options, like every office is going to be slightly different, right? In some cases, hey, maybe we have off hours security to make sure that nobody's breaking in, then make sure that the staff stays safe. Hey, sun is going down. We have security walking staff members to their cars. This you see often in hospitals, and we should see it far more often in hospitals, honestly, with the amount of crime that occurs in that in between, right? Because it's not just talking about workplace environment within the four walls on a roof, but sometimes you got to go to a parking structure.
Yep.
If you got to go to that parking structure from the moment you walk out that door, that front door to, or back door or side door, whatever door it is, to the car, you are vulnerable. Now, should you feel vulnerable? No, absolutely not. Sometimes there's ways to get around it, right? So if the parking lot is poorly lit, there you go. Boom. Hey, after the sun goes to sleep, as nighttime comes, as dusk occurs, we have a buddy system. You can't go by yourself, or you have to go with a member of security, or you know what I mean. Like, so there's different ways to mitigate training and security and prevent the workplace violence that does occur, right? um the burnout one, the fatigue one is hard to do because depending on your specific job title, it can cause burnout. You know what I mean? And
Talking
other
about like
roles don't.
absentee, what is it? Absenteeism
Yeah,
or
so
attrition.
absenteeism can cause burnout because then those that aren't absent are having to work longer shifts, right?
I
Right now,
read it an example. It was a delivery nurse at a Florida hospital. She resigned after repeated threats from a patient's partner. And
after being what?
she resigned after repeated threats from the patient's partner.
Yeah, no, that's wild.
And
That's wild.
apparently the hospital lacked a response protocol. And then she filed a hostile work complaint, and the hospital was
And
forced
she's gonna get
into
paid. And
and
she's gonna get paid on that.
the hospital was forced into a state level investigation. So you know where
Hmm.
that went. But I read
But see,
something
that's
too.
the kind of thing that I'm talking about, right? Like, okay, if we've identified in the hospital that this patient's spouse does not respond well to a specific staff member, we have a couple of no nonsense, low to no cost options. Rotate that person out.
Exactly, which is what the
Well,
hospital failed to
that's the
do.
easy one because there's usually more than one RN in any department, right? So, okay, cool. Susie, you're handling my case because patient hates me. Patient spouse hates me. We have a history, whatever the case may be. You know what I mean? Like, these are simple, simple things that we can all adjust to. And there should be protocols and training in place. It's it's wild. I mean, absolutely
It,
wild.
it's just wild to see it go to those lengths, for something
I
so
mean,
simple, you know.
So I don't know if anybody remembers this. This was probably about a year ago now. The New York City motorbike Karen, where the pregnant nurse had just gotten off of work and was going to get an e-bike, and then there was a whole standoff between her and some youths that also had an e-bike that claimed that they had rented the e-bike, and video went viral and all this stuff, and the hospital went and actually administratively punished her until things got cleared up, and then she sued. That case should never have happened.
No.
You have a pregnant staff member leaving work after a 10 or 12-hour shift. She should have been walked to her transportation. If for no other reason than she was visibly pregnant. You know what I mean? Like, I don't want you falling. If you
No.
fall right now, that slip and fall case would be awful. Again, just on the risk management side, there's a reason why facilities tell patients, no, you have to stay in the wheelchair. Even if you came in for something for your arm, you have to stay in the wheelchair until you're out the front doors. Why is that? Because they don't want a slip and fall case
Yep.
that can cost them hundreds and millions of dollars, hundreds of thousands, millions of dollars because of stupid things. You know what I mean? Um, it's Workplace violence is an easy thing to avoid. Some can be addressed easily, some cannot. And there's always, no matter what you do, there's always going to be that one person that breaks the system, right? No system is perfect, but if we can show that we had policies and procedures in place, that we had tested, that we had trained, and we'd followed, and there was something that occurred, the amount of fiscal responsibility after the fact is going to be minimal in comparison to head in sand, let it happen. It's fine. It's not an issue. We're not going to address it for pick a reason, right? If I'm a small office, having doors locked, buddy system after dark, um, having regular partitions between staff and patient. These are easy things that most people do through common sense, anyways. Oh, hey, we're just talking about something. Oh, hey, where are we going after work? Like a lot of that stuff happens anyways in a smaller office, but in a larger setting where you have different shifts, different people, it can get rather muddy rather quickly. So we've got to make sure that we're doing everything properly, right? So much so that, I mean, we had one office that we were consulting for where the office manager never, along with some of the providers, never left work before like 7:30 at night. I don't know how they had a personal life. I don't think that they did. So what the owners started doing was leaving flashlights. Like they had a little mini mud room on the way out. They would have a bank of flashlights. Take one to help guide you to the car and then bring it back, the next day or whatever.
Right.
That helps because you're not forcing them, hey, get your phone out, use that as your light. But working 7:30 to 7:30, 8 a.m. to 7:30, that every single day, that will cause burnout. It's not a matter of if, it's when. One of the major problems that we're having right now is providers, and a lot of them are having fatigue, they're having burnout, they're having substance abuse issues. And when I say substance, I'm not saying they're smoking crack in the bathroom. I'm talking about things that are far more pedestrian, but still just as damaging, like alcohol abuse,
Yep.
or prescription medication abuse. These are things that happen on a frequent basis. Emotional breakdowns from providers because they're having caseloads of 40 patients a day, and then having to get the notes done before they go home. You have to participate in canned medicine then. You have to have AI filling out half the note because you've got 40 patients in your 9-hour day. It's a criminal amount of patients. There's no way you're spending the proper amount of time with these patients. There's no way you're hearing the patients. So as you're reaching, there's a sweet spot. There's a peak performance level for everyone. And one of the things you've got to do as an administrator is find where that peak spot is for your resources, right? So, hey, what's my break even point? Maybe my break even point is 20 patients a day per provider. Okay. What is the optimal point? The point at which we're finding that peak performance, right? Maybe 30 is where our maximum is for some providers. Maybe we have a real solid workhorse that no, this guy can push it. He can do 35. Remember, this is all based on averages, right? Some days it may be down to 25, some days it may be 45. But if you put that average at a high arbitrary number, not basing it off of anything other than profit margin, you're going to have an issue. It's not a matter of if, but when. So you got to figure out, all right, we got to capitalize on our resources, our manpower. Okay, maybe the sweet spot is 30 per provider because sometimes it'll fluctuate. Some days it'll be 25, some days it'll be 40, but we average at 30. That's what we shoot for, and we go and punch it, right? And we just go through our day. It's a safe, you want to find that number that doesn't cause more friction, right? Because it's not just the providers that are physically seeing the patients, but it's the support staff. Every
Yep.
single one of those patients has to probably do a prior authorization nowadays, right? Depending on your specialty, you got prior auths. You've got to run the insurance. You got to deal with the patient. You got to collect the copay. You got to check their, you know what I mean? Like you just go through this so much. You got an MA that's checking in 30 patients. Usually an MA is working with multiple providers. So it's not 30 patients anymore. Maybe it's 60 patients now. That girl's got to have skates. You know what I mean? Like, so there's different things that we can do to optimize these things. Um, and then, hey, what about the labor hours after the fact? Because one person runs over, that trickles down your entire day. You start on time, you're like, hey man, we're pitching a no-hitter. 10 a.m. hits. Patient with 5 minutes over. They could have been late. Doctor could have gone to the bathroom, had to answer a message in between. It took a little bit longer than expected. Anything could have happened to cause a 5 minute delay. The problem is, can you make up that 5 minutes, or does that 5 minute snowball into 45 by the end of the day? 45-minute delay, hour delay by the end of the day can cause, on a short term, you're looking at a labor hour cost. On a long term,
Absolutely.
there's issues of staff members not being able to pick up their kid on time, or because extended day only goes so far. You've got issues of traffic, or you know what I mean. Like there's all kinds of downstream issues to not being able to work on a consistent manner, right? So there's a lot of different things. You running late 20 minutes causes the front desk people, their stress level skyrockets. Either that or their give a shitometer drop to the floor.
Got to be accountable.
Again, this is how you get people that they came in bright-eyed and bushy-tailed when they started with you, and then 6 months in, they're clocking in, clocking out, not giving one duck. So there's a lot of things that can cause workplace violence. All this study from the American Hospital Association did was just say, hey, we need to be more proactive as an industry. I wouldn't be surprised if they use this to try to leverage higher reimbursement rates, even though they just got a 2.9% bump last year, and they're looking at another 1.5 or something like that this coming year in reimbursements, while we're getting hosed on the outpatient side. So,
What would you say your CTA is? Jose, as far as
CTA, break that
yeah,
down.
call to action.
Call to action is simple. Do you have policies and procedures for workplace violence? When was the last
Gotta have
time
them.
you trained on them? You know what I mean? Like, hey, and you should role play. Now, should you role play in the middle of your busy day, middle of the thick of it with the patients? Maybe, maybe not. That's an internal discussion. However, you should be able to quietly, right, set up certain things. So, for example, bank robbery occurs when they trip the silent alarm. There's a reason why it's silent. Hey, maybe you go into a quiet lockdown real quick to test all the doors and windows. All right. Boop. When a patient tries to come in or a patient tries to go out, you say, hey, just give me a hot second. We're testing something. And then you move on, right? Like, but you should be able to do all of these things. You should be able to assess, hey, we're locking all these doors. Do we have an alarm system? This door doesn't lock for some reason. Well, then the alarm won't fire, won't activate. Or if it does activate and you have a locked door and you don't have a locked door, when it opens, it should go off, right? Like, so there's different things that you've got to test. Once you test, you train. Once you train, this is where the collaboration comes into play. You go and talk to the team. Hey, is there
Continuous.
anything that you guys think is missing? Make them part of the solution so that way when and if something does occur, they have some accountability. Right? You can't hold people
Absolutely.
accountable if they didn't know weren't supposed to do something or they were supposed to do something. If something is dictated to them, they are not going to take ownership of any of the outcomes. They're going to push it to you. Right? This is Simon Sinek. Yeah, I love hearing him.
I like
He's
him.
he's changing the way he changes the way people should look at businesses and HR and the human as a resource as well as a team member. Um, but again, you look at it and you go and say, "Hey, where does the blame fall? The blame always falls on those who have the crown, and that's okay. That's the job. That's why you get paid more. It's the reality of business. You want to know why a CEO makes $20 million a year and their bottom line employee makes minimum wage? Because if something goes wrong on a policy side, on a business rule side, on a marketing side, that person that clocks in, clocks out has no responsibility. There's no flack for them. It's all on the guy up top. So we've got to be able to go and change the way that all that works, or the way that trust and collaboration occurs. So I hope that people kind of can internalize a little bit of what their situation is, and then be okay asking for help from the team. Hey, we have this problem in the office. How do we get around it? One quick one. There's a couple of offices that I know that are provider owned, and some of the providers conceal carry. I'm not going to get into the politics of it. None of my business. I'm kind of indifferent about it anyways. My concern is, are people trained? If you are going to go and say, hey, it's okay for staff to carry on at work, depending on your size, again, all of these other risk factors, that may be something that is an intelligent move. It may not be intelligent. It depends on a lot of different factors. Are your people trained in the use of said weapon they're carrying, or is it just their dee 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 dee? I think it's cool to carry, and so I carry. I can't tell you how many
Do
times
you have a
I've heard
concealer
the concealed
license for
carry pass
starters?
is, huh?
Do you have a concealed license for starters?
I mean, some states you don't, it's not
Well, that's
required.
true. That's true.
And some states you can open carry without a license, right? So, but my concern is still the same. When was the last time you fired that weapon? Do you understand the basic rules of of firing safely? Or was the only time that you fired that gun was to get your concealed carry license? You fired into a barrel one time. They gave you a certificate. That's wild, right? I wouldn't let someone who's doing Botox on me, hey, this is my first time, and no one around ever.
No,
You know what I mean?
no, I get that. Um, that's a good example. There obviously are some basic weapon training outside of your getting your concealed that that you
Absolutely.
can take.
You,
And as an
the
employer,
cost of a
I'd feel more
self-defense
comfortable if
class.
you had that sort of level of training.
Well, I
At
mean, the
minimum.
cost of a self-defense class can be anywhere between a couple $100 to a couple $1,000 based on a variety of factors. But the fact that you could use that as a team building exercise and it's relatively inexpensive and it helps your team out, I mean, the juice may be worth the squeeze on that rather than taking them to Dave and Buster's for the umpteenth time and paying for their first two drinks. You know what I mean? Like it's at that point, it'll definitely be cheaper than Dave and Buster's.
And make it
It's
productive.
and for those of you that don't have Dave and Buster's, think about it as Chuck E. Cheese for adults. All right. So I mean, again, what are we doing? Workplace violence. We can't stop it from occurring. There are certain things that we can do to mitigate said occurrences. But if someone has ill intent and they have time and intelligence, they're gonna find a way to do it. All the best that we can do is the best that we can at preventing and then adapting. If it's an external issue, lock the doors, get everybody secured and isolated, make sure the police are are coming in to handle the situation. If it's an employee, how what are we doing to disarm that person, or are we just isolating everybody and trying to give them as little room as possible to lose their mind, right? I mean, the healthcare environment as it is has a ton of weapons on site. You know, like
True.
I mean, you don't need to be John Wick to be able to do damage in a healthcare office, right? From all the different things that are on site. So we just got to be aware of what those things are that can cause damage, who has access to them, how do they have access to them, and go from there.
No,
So,
absolutely. Absolutely.
any questions, any concerns?
Anybody has any questions, please feel free to throw those in chat, and we'll take the next few minutes to answer.
I mean, I mean, an example of this we could easily use. I was in the middle of Alabama with no internet signal, and somehow I heard about this whole Minnesota shooter guy that shot a senator, what was a state congressman and a state senator.
Yep.
This is a guy that had time, supposedly, allegedly, all those caveats in place.
Plan.
But to do that kind of setup where a person dressed up as a cop showed up in a law enforcement vehicle, introduced himself
Pretty
as law
interesting.
enforcement to gain
Pretty
access.
interesting.
Yeah, I mean, so assuming that the story is the way that the story went, right? That the only thing we can do is what is our response, right? What if this would happen at the Minnesota State Capitol? What's the response for okay, a shooter's on site? We got to treat our workplace like schools nowadays. What's that lockdown situation look like?
Yeah, no, agree. Do we got
Who
to call the
who are the
SWAT team,
people?
or
Yeah, who are the
or is
people that are
there
gonna go?
or is there
Go
a
ahead.
agency that a response agency or some of some sort,
I
or is it
mean, and
just
I'm gonna
law
go ahead.
enforcement, or is it just, your local law enforcement in that area,
I mean,
I would wager it'd
so
probably be on the SWAT side of things, but.
if I'm
for
looking at a
those situations.
hospital, a lot of hospitals have like off-duty cots in their ER waiting, right? Logging people in and out. But have you seen a lot of people's hospital security? I've seen mall security that tends to look a little bit more
It's tough
appropriate
because
or competent than hospital security. What, are
that
you kidding
security
me
has
right now?
become a minimum. It's like a minimum wage gig.
Well,
There's no requirement or no, at least from what I've seen. I mean, it's not even just
so
hospitals. It's like hell, your DMV or any of those places.
sometimes you get what you pay for. You know what I mean?
That's very true. It's very
What's
true.
the point of having security that is off duty or even on duty police and law enforcement that are checking people into the ER, but then on the other side of the hospital, someone can just walk in and security is not it's a race on wheelchair, on motorized scooters. Like, come on, we've got to do better, right? Like something simple. You mean to tell me that you can't get someone that looks competent, that looks the part for $30 an hour? Yeah, it
Yep.
may be a little bit more than the $15 an hour minimum wage, right? At least here in Florida.
But it's
But
the
the
optics that come with it,
well,
you
I
know?
mean,
You're like, oh,
the appearance of grandma being the security or a guy that clearly cannot chase me down is going to be completely different than someone who looks the part.
yeah. Yep. I
If they
agree.
look the part, the person that had ill intention may second guess themselves or
So in
may
other
not
words, the
do.
hospitals aren't taking it serious enough is what I'm
Of course not.
yeah.
I'm not.
What
Of course not. But that's why they're having to pay through the nose on the back end. If your security doesn't know how to restrain a patient that's going wild, or a staff member, or a spouse of a staff member, or a spouse of a patient, you have a problem. If they can't react quickly, you have a problem as a facility because you're spreading them out too far.
yeah.
You know
Yeah.
what I mean? Like all of these little details. If you're a small office and you don't have a security system like an ADT or something like that, or Simply Safe or whatever. We're not sponsored by anybody, so I'm brand agnostic for that.
Safe
But
touch.
Safe Touch, sure. I mean, whatever. You gotta have some kind of security system for your team.
Have to.
If for nothing else, then for the team to know that they can go from outside to inside and the building is secure. You know what I mean?
I'd
Something
say that's a
simple.
minimum. At minimum, you got to have a
That's a
security system
that's
in
an
place.
absolute minimum. Do you know how much as an ADT will
I know that.
charge? It's $100 a month for a small office.
Yeah, it's nothing. I'm
If
trying to
you're in a
remember. I'm
larger
trying to remember what we
building,
were paying when I worked for the weight loss clinic. I mean, it was less than that. I think it was.
it was less than $100 a month. Now, if you're in a larger building or a hospital or just even just a professional building, they should have security. So not only do you have a unit security, but you have security for the perimeter, for the external space. Why not?
Yeah,
You know what I mean? We've got to if you want to be serious about workplace violence, you've got to deal with the internal problems and the external problems. Some are cheaper to deal with, but no matter what, the prevention's always cheaper than the after effect.
in the post.
Yep, yep, yep.
Well,
So
cool. I
with
don't
that
see any.
said,
I was gonna say I don't see any questions coming in, so I'm gonna
yep.
say it's safe to say you did a good job, Jose.
Ah! At least I hope I didn't bore anybody. I try not to be boring.
No, it's definitely a
So
subject that's come up over as a recent, especially with everything going on, as you mentioned, these types of situations. So I think it was a good one to cover.
I
Um,
mean, and maybe down the road we address it again on a hey, so there was a verbal altercation between employees, and we'll break it down that way, and we can go over different recourses and things like that. If people are interested in that, just let us know. But this was a little bit more generalized, just because of the way that the study occurred. The study was very broad, and was focused on the financial impact. So.
No,
What do
absolutely.
we got in the docket next week, man?
So right now, it's actually to be announced.
Okay.
Um, Dr. Delgado wrote an article. It kind of relates to this in a sense, but understanding employment at will.
So
Uh,
yeah, okay. Yeah, we can go over that one. And we can kind of tie in 1099 versus W-2 as well, because there's different factors there and different liabilities for employment at will.
I think that would be a good one to talk on. I mean, it
Yeah.
kind of correlates with this side
Well,
of it
so
in a sense, just because at the end of the
yeah.
day, we're talking about employees, and this is. I think this one might be a good one. That
And I mean, again, employee separation is never fun. And anyone who finds enjoyment in separation, I'm just gonna go ahead and diagnose you from my desk chair as a psychopath. You know
I
what I
know.
mean?
I
Like
know we've discussed termination in the past, but I think not necessarily the employment at will stuff. So I think
employment at will, and I want to say that half the states in the US are employment at will states. So, I mean, if you're in one of those jurisdictions, you need to be aware of that. And if you're not in an employment at will state, sometimes you got to know how to fire somebody. When can I fire somebody? When can I not fire somebody, right? Or how can I not fire somebody? And there's a lot of different ways to couch that. And surprisingly, the compliance regulations can assist you quite a bit. So, yeah, that'll be
yeah,
that we can dive into a little bit.
we'll put that one on the docket for now. And
Yep,
if anybody has any suggestions or would like us to talk on something specific, let us know. Feel free to throw a comment in the chat. Would love to cover it. I know we've had some audience members give us some suggestions in the past, so anything appreciated.
yep,
Um, but other than that, appreciate everybody joining in. Jose, appreciate your time as always. I guess
definitely good to be back.
one final thought. Yeah, right. As far as the violence in a workplace, if you don't have a training program in place, get one. Would that be compliance? Workplace violence is covered in our OSHA training. We have,
Even if you have one, ask your team.
yeah,
Do you know where our policies and procedures are? And be specific because they'll pick out policies and procedures for how to use a machine or a certain type of machine that you guys have. No, HIPAA, OSHA, OIG, like be specific about it. And if they say, do we even have those? You don't have them, right? Because if they don't know it, you're going to fail an audit.
absolutely,
You're going to fail
absolutely,
an after action report, which means that you failed. So it doesn't matter. So make sure that you train on it. Make sure that at the very least, everyone knows where it is because you can't hold people accountable if they didn't know what the rule was.
absolutely. And if you don't know where to start, please feel free to reach out to Jose or myself. We'd be glad to help you out and provide some direction. Um, Again, don't be shy.
Yep.
Other than that, Jose, again, appreciate your time. Thanks for everyone joining in. This video will be on our YouTube channel. Hopefully by tomorrow, everybody will receive an invitation to next week's webinar as well as a link to recap that as well. If you're not already, please give us a follow or a like on our YouTube channel. This is where we post all of our episodes right now. We just got on the Spotify podcast as well under the Healthcare Step by Step podcast. We're on Apple as well. Still working on getting those episodes caught up. We've been doing these since October 2023, so it's been fun getting everything uploaded on there. But like I said, our YouTube's the most up to date. Like I said, just stay on the lookout. We will be posting this session on our YouTube channel here shortly. Other than that, Jose, we'll see you next week, and
Yep.
everyone stay out of trouble.
Have a good one.
Have a good day.
Sunshine.